The next high-risk situation we're going to talk about is infection. And infections in pregnancy are responsible for a significant amount of morbidity and mortality, and some consequences of maternal infections will last a lifetime, like maybe causing infertility or sterility. You also can have psychosocial results, and that can include altered interpersonal relationships and lowered self-esteem. Now, congenitally acquired infection can often affect a child's life by the length and quality of life. And so you have to think of both mom and baby in the assessment of maternal infection. Pregnancy is regarded, we talked about this in second semester, as an immunosuppressed condition. You've got altered immune responses, and this can decrease the maternal ability to fight infection. And then you have a more susceptible genital tract because of the lowered pH. Advancing pregnancy also causes the vaginal walls to engorge and the cervix to enlarge, which increases the risk of infection. We're going to talk about the different infections of pregnancy: bacterial, sexually transmitted infections, viral sexually transmitted infections, and then some other genital tract infections. So we start with the bacterial, sexually transmitted infections. Remember, the definition here is any microbe that is passed from one person to another through close, intimate contact is considered a sexually transmitted infection. First one is chlamydia. It's the most common bacterial STI, it should say. About 3 to 5 million adults are infected each year, and it is transmitted by direct sexual contact or the infant gets exposure at birth. It's very, very difficult to diagnose because it's often asymptomatic. Remember, that's our most common sign with women, is that they have no symptoms at all. The concern during pregnancy is that for the mother, they can have a spontaneous abortion or preterm birth, or they can have postpartum endometritis, which would be an infection of the endometrial lining of the uterus. For the neonate, they can have low birth weight. They're 10 times more common to have a stillbirth and 10 times more common for the neonate to die. A third of the exposed newborns will develop conjunctivitis, and that's chlamydial conjunctivitis. That's why we give the eye ointment at birth. And then 25% of those babies will actually develop pneumonia. So it has some pretty significant neonatal effects. Next is gonorrhea. Now this is also an STI, but it's also spread by direct contact with infected lesions and indirectly by transfer from inanimate objects. Its incubation period is 2 to 5 days, and the symptoms here are lower and upper urogenital tract infection, but again, usually only mild or asymptomatic in women. So the infection during pregnancy, the maternal effects are risk for preterm birth, premature rupture of membranes, chorioamnionitis, which is infection of the chorion and amnion, the two membranes that make up the amniotic membrane, and then acute salpingitis and arthritis. The neonatal effects are also conjunctivitis, pneumonia, and they can have other infections like the nose, the pharynx, the ears, the vagina, the anus. If they had a scalp electrode from an internal fetal monitor, that can become infected. So any opening, basically. Syphilis is the next one, which is a bacterial, but remember, syphilis is caused by a very weird bacteria, a spirochete. It's a spiral bacteria. and its incubation period is several weeks. With the early infection, they may be asymptomatic. Remember, we talked in second semester about the 4 stages of the disease. And in early pregnancy, just our regular early pregnancy symptoms of malaise and anorexia, that nausea, that can mimic those of secondary syphilis and therefore delays the diagnosis. So sometimes confusing to diagnose. Now, infection during pregnancy, for the mom, late abortion or stillbirth. With the neonate, they can get congenital syphilis, and this occurs when the spirochetes cross the placenta after the 16th to 18th week. They can have that rhinitis, that constant running of the nose, cracks and fissures around their mouth, hydrocephaly, and they get corneal opacities, so they actually have cataracts. There are no residual effects to the fetus if the mom is treated adequately before the 5th month of pregnancy. But if those spirochetes cross the placenta after that, then we have a problem. And these infants, by the way, don't live very long. Congenital syphilis is highly fatal. HIV, human immunodeficiency virus. The transmission is primarily through the exchange of body fluids. Remember, the seroconversion occurs within the first 10 weeks of exposure. Now, all women who are pregnant should be assessed for the possibility of HIV exposure. We should be screening everybody because we really cannot determine by visual look who could have it, who could not. And it's a huge issue during pregnancy. The most common presenting problems that women present with are chronic vaginitis and chronic yeast infections. And then when they follow them further and screen them, they are positive for HIV. Now, the methods of transmission to the fetus is in the first trimester just through the maternal circulation, but they can also become, that transmission can occur by inoculation or ingestion of the maternal blood and body fluids during the labor and birth, or through breast milk. Now, the important thing about the HIV is that we want to determine if mom is positive because she can be giving medication right away, and that decreases that transmission to the fetus by about 50%. So that's huge. HPV, we're talking about viral now, viral STI. It's the most common viral STI. It's sexually transmitted, and they have lesions that are called condylomata acuminata, which are dry wart-like growths. They appear to look like cauliflower. They are on the vulva, the vagina, the cervix, or the rectum. It's very, very difficult to treat the actual lesions. You can use cytotoxic agents, laser therapy, cryosurgery, but the recurrence rate is very high, up to 70%. They can be so large that they obstruct delivery. And the neonatal effects here are respiratory and laryngeal papillomatosis, where they actually have these wart-like growths on their respiratory system or their larynx. Now, other genital infections, first one is torch infections. TORCH, T-O-R-C-H, stands for, it's an acronym for several different infections. T is toxoplasmosis. O is other infections. One of those is hepatitis. R is rubella. C is cytomegalovirus, or CMV. And H is herpes simplex. Now, these torch infections are capable of crossing the placenta and then can adversely affect the development of the fetus. And all of them produce influenza-like symptoms in moms. Toxoplasmosis is a protozoan. infection, and it is associated with consumption of raw meat or poor hand washing after handling infected cat litter. So things like raw hamburger, not recommended during pregnancy, and we recommend that women do not handle cat litter, change the cat litter at all because of this risk. Fetal effects is that we can actually have a spontaneous abortion. Women don't seem to have any actual maternal effects, but we treat the mom with sulfa or clindamycin. Now the other infections, others that fall into this category are several. Mono is one of them, but it's the hepatitis that seems to be of concern. The hepatitis A, and this is a virus that's spread by droplet. Fetal effects are a spontaneous abortion, fetal anomalies, preterm birth, fetal and neonatal hepatitis, and then you can actually have intrauterine fetal death. With hepatitis B, the virus is spread by blood and body fluids, as well as hepatitis C. And the fetal effects here are low birth weight, prematurity, and a risk of this child having later liver cancer. Rubella is the R of torch, also called German measles, and this is transmitted by droplets from an infected person's sneeze, and the fetal effects here are spontaneous abortion or congenital anomalies, and the big one here is deafness. When we talk about fetal effects or risk factors, we always say they're at risk for this, that, or the other, and it may or may not happen. The issue with rubella is that deafness is almost always an effect with these babies. It is such a high probability. And then CMV, Cytomegalovirus, this is a primary cause of congenital viral infection in the fetus and the neonate, and most of them are asymptomatic, so it's hard to really know. But the fetal effects here would be hemolytic anemia, jaundice, they can have hydrocephaly or microcephaly, and pneumonitis. The treatment is, unfortunately, no real effective pharmaceutical treatment, so we focus on treating the symptoms. And then the H in torch is herpes simplex. There's type 1 and type 2, and the transmission occurs when the person is shedding the virus. Remember, they have a lesion that is like a blister, very similar to chickenpox blisters, although not the same virus. But when that blister is open and weeping, they are shedding the virus. Once it is dried and crusted over, they're no longer shedding it. About 10 to 40 million people carry herpes simplex type 2, and the symptoms for the patient are always more pronounced with the first infection. That primary infection is the worst. The transmission to the fetus is via the infected birth canal during birth, and the risk to the fetus is greater, again with that primary infection. So any woman who has active, open, weeping lesions is going to have an automatic C-section to prevent the transmission to the fetus. So we don't have transmission to the fetus just during the pregnancy. It is during the actual birth through the birth canal. The last infection, genital infection, is group B strep. And this is a very serious disorder. This is asymptomatic colonization. So women and men can just be carriers of this group B strep, and it doesn't affect them in any way at all. They may not even know they have it. But vertical transmission from the mom to the baby occurs near the time of birth. So 50 to 75% of the time you have this vertical transmission. And this is the most common cause of sepsis, group B sepsis, in the neonate, and it's very life-threatening for the baby. Therefore, the preventive treatment is penicillin, Penicillin IV during labor. It's given as soon as she arrives in labor and then every 4 hours until she delivers. It does not help to treat her in pregnancy whatsoever because the transmission doesn't occur until just before birth, and the other part of it is that she is a carrier, so she's always going to have it. So you're trying to just prevent transmission to the fetus. And also with the group B strep is that we want to be sure that she gets treated appropriately in order for that baby to be protected. She needs to have at least one dose at least 4 hours prior to delivery. If not, we need to follow the fetus for any signs and symptoms of high risk with them. And we'll be talking about those high risk infants in class. This is going to end the part on infections for the high risk, and we'll start with drug dependency in the next taping.